Hi, I'm Ruth Werner, and I want to thank you for joining me for this little audio-visual sidebar to my column, Multiple Sclerosis, a Viral Complication, New Ways to Think About a Familiar Disease. And this will appear, I believe, in the July-August 2022 edition of Massage and Bodywork magazine. In this little video, I'm going to go through the most commonly recognized subtypes of MS, and then I'm going to share with you some conversations that I had with two people who live with this condition. Neither one of them gave me permission to share video or audio, so I will just share some interesting things that they told me to give you an idea of what living with MS might mean for your clients. But first, let's talk about subtypes. There are 6 predictable patterns that MS can take. The relapse-remitting form is by far the most common, but some people will start with this type and then progress to something different, and this is what you'll hear in one of the descriptions that I will share. One important thing to say about MS is that our understanding of this disease has undergone big changes in the last 40 years or so, and people diagnosed with MS today have many more treatment options available to them than people diagnosed 20 or more years ago, and that has a lot of influence on their prognosis and their life expectancy. And with the clarification now of the link between multiple sclerosis and Epstein-Barr virus that I describe in the article, even more treatment or prevention options may soon emerge. So here are the types of MS. Clinically isolated syndrome is a situation where an episode of symptoms lasts at least 24 hours, and central nervous system damage can be seen with magnetic resonance imaging. It can involve just a single area, like a bout of optic neuritis would fit this example, or multiple areas, like optic neuritis along with numbness or tingling in the extremities. A person with a history of clinically isolated syndrome may go on to develop MS, but it's not always a foregone conclusion. Certain aspects of clinically isolated syndrome can predict the likelihood for developing MS, and this is important because it allows a patient to begin treatment early for a favorable outcome. Relapse-remitting MS affects about 85% of MS patients, and they cycle between stages of flare and remission. While some recovery of the myelin sheath can occur between flares, ultimately some accumulation of permanent damage is usually inevitable. Progressive relapsing MS is a subtype of relapse-remitting MS, and this form involves a slow but steady decline marked by periods of extreme flare. Primary progressive MS involves a chronic low-grade progression that is not marked by periods of acute flare or remission. Secondary progressive MS involves cycles of flare and remission, but recovery during remission is only partial, and the patient experiences a progressive loss of function over time. And malignant MS involves a fast, relentless decline, leading to disability and death within weeks or months of diagnosis. And now I'd like to talk with you about Mary. This is not her picture, and Mary is not her name, but this person, who was a massage therapist in private practice, generously shared a lot about her experience. She's just not eager to share identifying information, and I completely respect that. So we're going to call her Mary. Mary is 44, and she was diagnosed with MS in her late 20s, which is pretty typical. She had been a dancer and an elite athlete, so when she noticed a sudden onset of feeling what she described as a loss of connection with her right hand, she knew something was off. I asked her to explain this loss of connection, and she said she could move her hand, but it took all of her attention and focus to do it. At the same time, she developed some visual disturbance for which she needed glasses. That resolved a couple of years later when she did some special eye exercises, and that was a great outcome. In those early days, Mary also noticed a loss of coordination and difficulty with walking, and she developed a new pattern of really severe migraines, one after the other after the other. And it all had a pretty specific beginning point. She said one day she was fine, the next day she was not fine. She underwent lots of neurological testing, including an MRI and a spinal tap. She and I agreed 1 star, would not recommend. And her diagnosis was conclusive. And in a way, that's really good because lots of people with MS struggle to get a clear diagnosis in their early stages. Mary has relapse-remitting MS. It's a scary diagnosis. She didn't know what was happening or what would happen next. Even today, nearly 20 years after her diagnosis, every time she has a flare, she wonders if this is the time it will all start to go downhill. Since she was diagnosed, Mary has had 4 children, including a set of twins. Sometimes being pregnant can provide a bit of respite from autoimmune diseases, but during pregnancy, Mary developed some other problems, including Hashimoto's thyroiditis, which is an autoimmune attack that causes hypothyroidism. Her flares come in 2 main varieties: small ones that can throw her off balance for several hours or a day, and major ones often attached to heat waves in her area, and those may persist for several weeks. Her smaller flares may happen with some frequency depending on circumstances, but her major flares are very rare, happening less than once a year. Her triggers include stress, that's not a surprise, and a rapid change in barometric pressure. But her most reliable trigger seems to be heat. She's a runner, but she has to run at night to avoid getting overheated. She can't go on hikes or do other spontaneous daytime activities because she can't get overheated. Those minor flares involve severe headaches, brain fog, vertigo, loss of coordination, and, as she says, sometimes whole new symptoms because that's always fun. Lately, for instance, she's been having some numbness and drop foot in her left leg, which puts a crimp in her ability to run. Working from home has been good for her because being on a strict schedule and rapidly changing environments, like going from home to car to office to car to home, that's really hard for her. Mary currently manages her MS mainly with diet. She's on a keto and gluten-free diet. She exercises and takes charge of all the things she can control, like staying out of the heat and minimizing stress. She has a healthcare team that she works with, but as long as she's not having major flares, she feels she's on a good maintenance track without medications. I asked Mary about her experiences with massage, and she has some interesting opinions. First, whenever she works with someone new to her, she asks them to err on the side of caution. She's had experiences that felt great in the moment, but over the next day or so, she realized that work had been too intense. Also, she hates having her fingers and toes pulled. She says, no, thank you. If a therapist does a lot of neuromuscular testing, they are also likely to get some weird results. And she does sometimes get painful spasms, often not where her massage therapist is working, and that can be a challenge too. The other person I interviewed is very special to me. She is my best friend from high school, and she's fine with me sharing her name, but not her picture. So we'll let this person stand in for my friend Carrie, who is 61. And she also was diagnosed in her mid-20s. And her first symptom was urinary incontinence. So she worked with a urologist. She went through lots of urological tests, which revealed nothing. Finally, her doctor said, this is not a urological problem. This is a neurological problem. She didn't really understand what that meant then. This was about 1985 or so. But, of course, she does now. Her neurologist then was able to establish clearly that she had some nerve problems. Her evoked potential tests, while painful, were clear, and she found this to be a big relief. Carrie said, it makes you feel really stupid when you can't use the potty right. But when I saw my nerves were affected, that it just wasn't like bad willpower, that something was really wrong with my nerves, well, that helped. And then the neurologist told her she had a spinal cord tumor. Fortunately, she went for another opinion and she learned that she has multiple sclerosis. But this person said, yeah, neurologists really don't like treating MS. It's so discouraging. In those days, treatment options were very limited. She was recommended for an intense 12-month course of chemotherapy to suppress her immune system overactivity, but was told if she wanted to have children, that had to happen first. Consequently, it was several years and 2 daughters before she began this treatment, which, as it happened, gave her all the negative side effects of chemotherapy without any benefits. She called for an end to that strategy when she felt that really her life was in danger. Along the way, Carrie developed several other problems. During her second pregnancy, she was on prolonged bed rest and lost a lot of bone density. Then she broke an ankle. The cast gave her a long-term pressure sore, which eventually required plastic surgery to heal. She went from using a cane to a scooter and then finally became fully reliant on a wheelchair soon after that. Carrie probably began with relapse-remitting MS, but it then developed into what is probably primary progressive MS. She doesn't have periods of flare, but she has ongoing and progressive loss of function. Most of the therapies for MS are useful for the relapse-remitting type and less effective for the progressive types. The chemo didn't work for her. Interferon medications didn't help her. She's allergic to the prednisone group of anti-inflammatories. This doesn't leave her with a lot of options. She says having her form of MS is a full-time job. She needs to catheterize because she has neurogenic bladder. She takes varieties of medications, including a statin, an antidepressant, a bisphosphonate for bone density, Neurontin for spasms, and drugs to manage constipation. She says her colon is on a permanent work stoppage. She has received some massage. She said it felt wonderful, but it didn't seem to change her MS in any way. I said, feeling wonderful is good, and she replied, yeah, but a hot fudge sundae works too. And I can't argue with that. The challenges that Carrie lives with every day are pretty huge, but she gets a lot of help, and she's grateful for the resources that are available to her. She knows there are many people who are struggling with MS who have a much harder time. I want to offer my deep thanks to Carrie and to Mary, who were both so generous about sharing their stories with you. I think hearing about 2 really different experiences with MS might help massage therapists to understand how variable this condition is. And when we have the opportunity to be helpful to someone who's living with multiple sclerosis, I hope we can step up to that challenge with compassion and maybe now some new insight.